Everyone, and welcome to this session on cancer treatment in UHC. We're just going to give everyone a minute or two to join us, and then we'll kick off. In the meantime, this session's supposed to be as interactive as possible, so if you do have any questions, please do feel free to drop them into the chat function or raise your hand and we'll come to you to pose your questions directly to the speakers. So we'll just be kicking off in a minute or so. Thanks so much. Wonderful. So thank you very much again, everyone, for joining us today. UHC is really the theme of the year this year, and as part of a series on cancer in UHC, UICC is convening an excellent group of speakers to really bring their expertise to the topic. And no series on UHC and cancer would be complete without a focus on treatment and care. And in particular, one of the things we've seen as a challenge within UHC is how we can develop policies and programs that really help to promote equitable and sustainable access to care, and also how we can track the effectiveness of these programs in really reaching the needs of communities and populations around the world. So often when we engage policymakers on UHC discussions, we get the same two questions: why cancer and how is it we do it? And the cancer community is certainly continuing to work against a series of assumptions or misconceptions. The cancer is too complicated, too expensive to complete within UHC. We're going to try and address some of those challenges today with our expert panel of speakers, which includes Dr. Miriam Matabi and Venus Musheninga, and hopefully very shortly Dr. Yehuda and Marte. Over the course of the next hour or so, we're going to be looking at how we can kind of work with governments and different stakeholders to really champion those policies and programs we need to address cancer inequities, whether that be in access to service, the affordability of services, and the availability of services. So without further ado, we're going to go into a little bit of housekeeping. So we invite you all to keep your microphones muted for the first part of the session, which is going to be an interactive conversation with our three speakers. From then on in, we're going to jump into a series of breakout rooms where we're going to encourage you all to exchange your perspectives and your experiences so far. And we're going to ask you three questions. What are some of the challenges that cancer patients are facing in your country or region? What would you like to see change by 2030? And what do you see as some of the opportunities? We'll then all come back together for an open Q&A session, and then we'll wrap up. Throughout the whole session, if you have any questions, we'd encourage you all to drop them into the chat function below, or raise your hands and we'll try and open up the mics to you. So without much further ado, it's my real pleasure to jump into the exciting part of the conversation. And I'd like to turn to Miriam first, if that's okay. Miriam, you're a surgeon by training, and we know from the Lancet Commission on Surgery that over 80% of patients will need some sort of surgical intervention over the course of their cancer journey, and for many, more than one. From your broad-ranging experience, what are some of the challenges facing cancer patients in accessing that cancer surgery that they need? But also on the flip side, what are some of the opportunities you see to address these within kind of that broader UHC conversation?
Thanks, Rosie. And I think you sort of highlighted a pertinent remark about 80% of cancer patients requiring some form of surgical intervention. And I think what we probably need to emphasize is that more than a third are going to require repeat procedures. and perhaps looking at sort of the contextualizing or situationing cancer surgery. What we do know and what might not necessarily be intuitive to listeners is that surgery really encompasses all the different aspects of the cancer care continuum. And so surgery can be diagnostic in the sense that you're taking a biopsy in order to confirm a diagnosis. It can be curative, where one goes and resects a tumor, for instance. It can be palliative or supportive. Sometimes if you have like a fungating mass and you're doing that to maybe facilitate the quality of care, or at least quality of life of the patients. And it can also be reconstructive, for instance, where we're recreating or doing limb salvage surgeries, or reconstructing a breast. But I think, Rosie, the usual argument around surgery, we always say surgery has been the neglected stepchild of global health, because what we do know, even if we sort of take a step back and not even think about cancer surgery, just surgery in general and global surgery, we do know that 9 out of 10 people on the planet have no access to safe, timely, and affordable surgery. Now, if we look at the biggest deficits are really in low and middle income countries, with about 143 additional new surgeries, procedures required just to prevent death or disability. And if we look at the projections that by 2030, we're going to need at least 43 million cancer surgery procedures, it's really trying to then look at how do we then balance what's required versus the current situation. And I think for the longest time, the supposition has been that surgery is too expensive. It really doesn't have its role in UHC. But then in terms of thinking about the holistic management of most cancer patients, cancer surgery, most times, at least depending on solid tumors, is a definitive treatment. So it's really thinking about how do we then start to have that conversation. Now, the reasons that patients are not necessarily accessing these services are a combination of factors. The broadest being the fact that patients have to frequently pay out of pocket in order for them to access care, frequently resulting in financial toxicity and catastrophic health expenditure. And so if you look at surgery generally, if you look at the different aspects of treatment, it's usually the highest ticket item that frequently results in patients getting financial toxicity. And so this is further compounded by poor and dysfunctional health systems, for instance, where sometimes patient needs a surgery but doesn't necessarily have the requisite skill sets or the reagents or different bits and bobs that are required in order to run safe, timely surgery. You always think about surgery as the surgeon shows up and cuts, but it's really around what makes a difference. And this is humbling to us surgeons. It's not the actual procedure; it's the pre and post care that's needed. So it's really around safe anesthesia, nursing, diagnostics that really help to support this. And then the third, again, being one of the aspects around social cultural barriers that may sometimes prevent people from accessing their cancer surgeries, things like stigma or fear of losing the breast, for instance, with a mastectomy, may sometimes inadvertently result in patients not accessing treatment in a timely fashion. So it's really that constellation or interplay of factors that ultimately result in patients not necessarily getting the surgical skills that they require. Some of the opportunities would be really around, we do have, for instance, I would say in many low and middle income countries, there's very few specifically trained surgical oncologists. And the bulk of training is supplied by general surgeons who do cancer surgery. And it's really around how do we homogenize the care that's being delivered. And so quite a number of initiatives have been around training the pre-existing workforce, because it's really about how do we get the workforce to be on the same page, such that the mastectomy you do in Puerto Rico is exactly the same as in Tanzania, or is exactly the same as in Ghana. So it's really around how do we homogenize skill sets. And I think there have been opportunities around with the digitization of I mean, we've had an increase in, I think COVID has shown us that we are increasingly interconnected. And so there have been opportunities for telementoring and learning, all of which are fundamentally are at least showing promise in terms of running preceptorships that help to enhance the collective body of the surgical skill set. But it's not just surgeons alone. It's really about that multidisciplinary team approach to care, and it's really getting all the different components, whether it's the medical oncologist, the surgical oncologist, the radiation oncologist, the nursing, to really work hand in hand in order for us to optimize our surgical outcomes.
Fantastic. Thank you so much for that, Miriam. And I think you're absolutely right. It's almost a parallel to the idea that it takes a village to raise a child, and it takes an entire health system to deliver that essential cancer surgery. And I think it's one of the really interesting things of the way you presented is almost we can look at sort of that surgical capacity as almost the acid test of a health system. Do we have those pieces in place to support that patient through that journey? And as you say, it's not just the knife and the room that the surgery takes place in. You've talked about sort of some of the opportunities and some of the challenges, and you said particularly in terms of the human resources for health. Can you comment on what some of those core investments do countries need to make to improve that access to surgery for cancer patients? And given that there are so many different domains that really feed into that ability to a patient to access care.
Thanks, Rosie. And I think one of the sort of beginnings of the appreciation of the importance of the role of surgery was really around the World Health Assembly, the 68th World Health Assembly, where we had the resolution that really sort of tried to position safe, affordable, and timely surgery and anesthesia care in the context of universal healthcare coverage. And it's really trying to think about there does need to be deliberate investments in health systems. And rather than sort of thinking about, I'm just going to go and improve surgical skills, it's really how do I improve the entire continuum? So if we look at in terms of investment in health and workforce, we are still lagging behind. I'm going to sound a little political, but then the optics sometimes for politicians is really in setting up, nice, fancy sort of cancer centers or, installing radiation machines, and then having a think and sitting back and saying, hang on, we don't really have the workforce to kind of run this. And so really a deliberate investment in the workforce will go a long way. We're still having the highest deficits in workforce in low and middle income countries, and with sub-Saharan Africa probably being standard out. But I think one of the things that we can do from an investment perspective is moving that conversation to training the workforce, but then also looking at how do we do in-country training, because again, we've also had concerns around skill sets where if training is not provided in country, then we have a lot of migration and lack of retention of the skill sets. So it's really looking at one, how do we empower, enable, and expand the existing workforce? And how do we then provide opportunities for retention, but then also providing an enabling environment? It's not enough to go and give somebody these proper skills and then they can't work in the environment that they're in. It's really going hand in hand with those sort of shiny new toys, really getting the back end behind that strengthened, that will help to enhance our optimal output for surgical care and delivery.
Fantastic. Thank you so much for that, Miriam. And I think you're absolutely right in terms of that. It's often, and particularly with UHC, one of the key things we've seen is we can invest in what you referred to, and I loved it, was as the shiny new toys, but actually the shiny new toys don't do anything by themselves. And it's the people that, as with everything in the health system, the people that make that difference. And there's one question that has sort of popped up in between, and it kind of picks up on your point around sort of the standardization of skill sets between countries and building the health workforce capacity. And that's how is it that we manage the right to health workers to migrate between countries versus sort of international recruitment, particularly from lower middle income countries moving to higher income countries? And do you have any thoughts on that as it pertains to sort of being able to continue to deliver on UHC?
I mean, thanks. I think we're trying to optimize. We've talked about it as not necessarily brain drain, but more like brain circulation or recirculation. So it's really thinking about, rather than sort of, it also calls for a bit of inner reflection. I mean, it's sort of thinking about, why are people migrating out, right? And what are the factors that would sort of, help them to sort of stay in country? Because if you talk to most people, I mean, they would usually have a desire or ability to, or a wish to, even if they're elsewhere, really wanting to contribute to their, parent country or home country. And so it's really about, less about blame, pointing fingers and saying, why did you go off and migrate? Because you still do need to pay your bills. It's really looking at, how do we tap into the diaspora, and how do we create a global community where we can, sit together, exchange ideas, and really push the needle in terms of improving, or collectively working together to improve care. And I think also really embracing that multidisciplinary approach also gives us that sense of a nuanced approach to cancer care. But then really at the end of the day, it still comes down to investment. Whether we all the digitization, the recirculation, unless we're deliberately investing in health systems, then we're always going to have this, continuing conversation around, how could we do better, or why are we not able to retain folks in country? And sometimes it's not even about remuneration. It's really around, what support do I have? What is the job satisfaction? So it's really doing a deeper dive into what are those nuances that would help to enhance or optimize care delivery. Because I don't think anyone goes to help sort of say to make money. They're all looking to make a difference. And so if we can get a situation where they're able to make a difference, and rather than feel that what's the point, then really we are steps ahead in trying to retain and engage our workforce in a consistent manner and in a sustainable manner. Thanks.
Fantastic. Thank you so much for that, Miriam. And I think I mean, it feels like investment in that health system, and the people that make the health system what it is could almost be the banner for UHC more generally. And really thinking about, the people within the health system, whether that be patients and whether that be kind of care providers within those multidisciplinary teams, I think is a core part of how we need to kind of approach UHC as advocates, as care providers, as patients, as citizens. I wanted to sort of pick up on some of the themes that you've raised, and when we're thinking about kind of investment, one of the elephants in the room, and if I can turn to you, Yehuda, is really, cancer medicines are often at the forefront of what people think about when we talk about kind of improving access to care within UHC. And so I wanted to sort of get your perspective on what opportunities do you see in these kind of UHC discussions to start addressing some of those inequities in access, because that's often what comes to the forefront of mind, and how we integrate that access for a core package of cancer medicines. I know that you've been working on this quite a bit. So Yehuda, over to you.
Yeah, I think, thanks. I think the issue of access to medicines is probably an issue that is, it's a conversation that we're going to have for a long time. And I think when we talk about a core package of access to essential medicines, we really mean the backbone of medicines for common cancers that we treat. And so, I think as we talk about UHC, there's been a disproportionate focus on screening. I think screening is important. I am not discounting screening, but I think there's been a disproportionate focus on screening, cervical cancer elimination, and this idea that, we can prevent cancers, but obviously we cannot prevent all cancers. And so I think as our UHC packages is starting to focus a lot on screening, and especially leveraging the WHO's focus on cervical cancer elimination and global breast cancer initiative, it's important to tie that in with treatment. And so I think the missing piece really is thinking about how we are going to maximize the benefit from screening. And we can only do that if patients can then be connected to a sustainable supply of medicines to treat their cancers at an early stage. I almost think it's unethical to screen people and then not have a guaranteed access to treatment. And so, I think UHC is, to make this an approach that is sustainable for a lot of ministries of health, we have to think about the cancers that are prevalent, the cancers that we focus on. And I think really maybe leveraging resources that are already available for cervical and breast cancer to maybe expand treatment in those dimensions would be a starting point. Like, I don't think cancers should be, countries should be having medicines for pancreatic cancer or immunotherapy before they have the core backbone. And so I think being able to decide which cancers are priority, and I think in most LMICs or even globally, I mean, LMICs, you'd have cervical cancer in addition to breast cancer, but I think globally, a focus on breast cancer makes sense. And so I think starting small with a UHC package. Cancer medicines can seem a bit daunting because of the cost of the individual medicines, but a lot of these backbones to actually achieve some marginal or even like great impact is really based on cytotoxic chemotherapy that's off patent, that's generic. And so I think, using the WHO essential medicines list as a guide, countries can start prioritizing individually to fit the cancers that they see. And I really think breast cancer and cervical cancers are the right approach. Anytime I say this, people say, what about the men with prostate cancer? So, that's also something to consider. But I definitely think the absence of cancer medicines on UHCs are not acceptable anymore. I mean, we know there's an increase in incidence, there's a huge gap in funding. And it's really not acceptable anymore to say cancer medicines are expensive and we can't do anything about it. I think the initiative within the childhood cancer space is inspiring, but I think, locally, ministries of health that are focused on screening can also dedicate part of their budget funding to just generic medicines for breast cancer and cervical cancer.
Fantastic. Thank you so much for that, Yehuda. And I think the point you raise around kind of the ethics of, if we're diagnosing someone, if we're screening someone, then actually, ethically, we can't then say, congratulations, you have breast cancer, cervical cancer, and then leave that person there. And and actually kind of, as you say, thinking through that patient pathway of, well, with this information, what does that patient do? Where does that patient go? And how do they interact with the healthcare system is really important. And I really like the point you were saying about, starting from breast cancer, starting from cervical cancer, starting with childhood cancer, and then building out. And so what do countries need to consider when they're selecting their medicines for UHC? If they are kind of starting from those starting points, how do they build from there? What is it they need to kind of bear in mind, and kind of how are countries sort of driving these improvements in access?
So I think a lot of initiatives now focused in this space, but I think a lot of countries, what we should realize is that a lot of countries are shifting from having only treated infectious diseases, which have pretty simple like regimens for treatment, to cancer that has a more complex multi-regimen approach to treatment. And so I think in terms of thinking about, selecting medicines, it's important to have some baseline sense of what your data looks like for cancer. So what is your incidence for specific cancer types? How many patients are diagnosed? How many patients will potentially be treated? How many medical oncologists you have? What would be the volume in these hospitals? So I think being able to do that at a macro level, but also with some granularity to be able to decide what specific medicines you should procure and how much you should procure. What we're having in some countries is that there's a little bit of a, not guesswork, but just like estimating how much you need and then running into issues of cancer shortages and then trying to scramble around for, additional medicines. And so there's that. I think there should be a systematic approach to forecasting, deciding what the volumes are, deciding like really determining how much you need to budget for the medicines. I think a potential mechanism, which, I preach about this, is like thinking about regional procurement. I think that might be a way to leverage expertise across the region. And so, the countries like Botswana or just like even islands in the Caribbean where just the individual country wouldn't be able to have enough volume to actually purchase these medicines at a cost that's, cost effective essentially. And so being able to leverage food procurement, either through the region or through like a disease-based food procurement, I think brings with it the benefits of economies of scale, being able to procure at a lower price, but also brings with it expertise. I don't think every Ministry of Health really has the expertise to be able to think about cancer incidences and forecasting and specific volumes and things like that. And so, I would say data, it has to be data-driven. I think there's a lot of wastage from medicines being procured without without basing it on data within country. And so you run into the issues of stockouts or medicines expiring on the shelf. And so I think, first of all, you start off with some data that estimates your burden, and then you forecast and predict how much you're going to spend and need based on that.
Fantastic. Thank you for that, Yehuda. And I think, yeah, as you were saying, it's, you know, really starting from the data that we have and the data that we know, and using that to build from there. And I think it was really interesting you were saying we often talk about regional procurement and pooling as a way of bringing down cost, but actually bringing in the expertise that other countries may have, or you may have across a region, I think is a super interesting perspective that we maybe don't hear quite as frequently as well. And so sort of thinking about kind of bringing in the expertise, Venus, I wanted to turn to you as our third speaker, as you worked within the Zimbabwean government for a number of years, and so I'm going to pick your brains if that's okay, because governments do have to balance these multiple demands on budgets with the expertise that they have within the kind of their ministries. And actually, how is it that we, as a cancer community, can start to work against some of those misconceptions that cancer is too complex, it's too costly, it's beyond the capacity of ministries to take action, as Yehuda was sort of referring to. So, I mean, I guess synthesizing that down into something that's a little shorter and easier to respond to, you know, how is it that we can kind of make the case for cancer treatment with governments? You know, how is it that we answer the why cancer question? Or how is it that you answered the why cancer question?
Okay, thank you so much. I think I have the hardest question. I think what's important to look at your context and see, actually analyze the stakeholder landscape, because cancer is multi-sectorial, multi-stakeholder. So then you identify the stakeholders that the government is willing to listen to, and then you work with them to bring the message to the fore. So, for example, in our setting, we had to rope in survivors, cancer patient survivors, to actually tell their story. Just from telling their story and highlighting the challenges, the government was able to listen better to their concerns. And also just looking at the technical expertise, because I think a lot of times when we approach our governments, we're just approaching them with figures. This is what we need, this is what we need. But having a compassionate approach to advocacy, because it was during those processes we then realized, okay, we can actually appeal to the experiences of the policy makers in terms of getting some your way in some areas, like resources set aside for cancer care. So that's just how you package the information and who you put in the front with the message. I think it's very, very, very critical, and to actually understand, because we are lucky, our government has got interest in non-communicable diseases. So then if you have that opportunity, then it's easier. Yes, I think that's my answer to that one. But also looking at strategic advocacy, presenting facts but in a palatable way, rather than bombarding them with data, figures. You package it. Yeah, it really has to be tailor-made for what they want. So if it's a time for campaigning for elections, you package it such that they say, okay, we can use this, we can make a difference, we can get people to like us. So it's becoming a bit political, but doing it subtly, I think. Yeah, I think that's one of the strategies you can employ. Thank you.
Thank you so much. And I love the idea of compassionate advocacy. I think that's a really lovely way of doing it, because I think often we can forget that the people we're advocating with are not sort of those technical expertise. So yeah, really thinking about how you bring together the hard data with the recommendations, with the patient stories, and what we need at different points in the political cycle. And we've heard some excellent stories from countries who are going into kind of elections in the next couple of years, and how they're trying to use UHC discussions as a way of trying to capitalize on those little kind of political windows. And I think, kind of another thing that we hear quite a lot, and Miriam and Yehuda have both kind of alluded to it, is this idea that particularly for cancer, we aren't in a position to do everything everywhere all at once, to quote the movie title. And so we tend to look more at kind of, well, here in Geneva, and we hear in kind of high level meetings a lot about kind of that progressive realization of services, so kind of building towards a longer term goal. And so what's been your kind of experience, both as an advocate and someone who's been on the other side of the table, hopefully being compassionately advocated to, around how we can tell a compelling story to get governments to invest in the long term in that kind of progressive realization?
All right, thank you so much for that. So that progressive introduction of cancer services is very critical to actually do a stepwise approach so that governments are not overwhelmed. So my experience has been, for example, just looking at access to medicines, like you were saying, that's a major challenge. So from my experience, when I started off in the private sector, the first thing was to bring in the medicines, get all the regulatory issues out of the way, then look at whether there's policy that is backing access to the medicines. So then supporting the policy that ensures that the medicines are available and they can be accessible. And also just working with other stakeholders, because like I said, cancer is multi-stakeholder. So we had to then engage non-governmental organizations that were already in the cancer space to say, we've addressed the medicines. What's next? Because that was the major hurdle initially. There was nothing. The patients had to import individually. And then we also looked at capacitation of the healthcare worker. The commodity is there, the drugs are there, but there's no one who is able to give the drugs, who's able to monitor the patients. There are no structures, laboratory systems, tests, and everything. So it was also looking at capacitation of the healthcare workers. So the process is being done mostly in parallel, but then focusing on which one was the major cancer. For us, it's cervical cancer is a big problem. So it was like sort of like the entry point to say this is the elephant in the room, and then progressively address the continuum of care. Then what we also did is integrating cancer services into the routine healthcare services. For example, cervical cancer screening. A patient comes in, we already have an HIV program. We had to make sure we're integrating with that. So looking at what is already there and not trying to create a parallel structure for cancer. Then they realize, we can actually address the low cervical cancer screening when the women come for their arch refills. So that was one of the things. So just maybe looking at mostly progressively from the government, as in the government, piloting to actually demonstrate your concept, and then progressively upgrading. And also one of the major gaps was the financing. It still is a problem, but when I started my cancer journey, no health insurance would cover cancer drugs, cancer treatment, cancer diagnosis. There was nothing. But then it was coming up with these innovative ways of saying, you already have pulled resources, you've already pulled funds, advocating for them to make sure the patients are treated early so that they incur less costs at the end. So it was engaging those multiple stakeholders in parallel for one area, and then everyone realizing we can add on other areas. And also one area that really helped was looking at the global landscape and realizing there are already patient access initiatives that we could leverage on for the more expensive drugs. So encouraging the private sector, and also I was in the private sector. So what we were doing now was we're doing commercial, but we also have that access initiative, the philanthropic aspects, corporate social responsibility, appealing to that to raise resources towards cancer treatment, and putting together people in one place like MDTs, and like I said, engaging the survivors, that really helps for that realization that it is possible to offer certain packages for cancer treatment, and people can actually have access. Yeah.
My apologies for that. Fantastic. Thank you so much for that, Venus. Those were very articulate responses to quite unfair and very large questions that I posed to you. But I think it's really interesting, as you say, kind of moving from that sort of presence to policy to collaboration to capacity building as a way of thinking about how we bring these different pieces together. And I think one thing that really came out when you were talking was about how we use sort of touch points that patients already have with the healthcare system to make sure that they're accessing the services they need. And I think it comes back a little bit to the point that Miriam was making, that, you know, actually when we're delivering cancer services, it's not just about an individual service in an individual room, in an individual building, in an individual region of the country, that actually, if we're going to see this succeed, we need to work out how we weave in with other kind of disease groups, but also other disciplines and other professions. And so I wanted to, we have somehow managed to keep wonderfully on time, which I attribute to the excellent speakers rather than my timekeeping. But what I wanted to suggest now is that we move into some breakout rooms for people around the call to be able to share their own experiences. And one thing that we wanted for you to do is we'll be opening up the chat rooms very shortly. And one thing we wanted to ask you to do was really to try and reflect on these three questions. Now is the opportunity for us as a community to sort of share our own expertise. So we want you to respond to, what are the key challenges facing cancer patients in accessing treatment in your country? Where do you think your country or your region has made progress? And what is it that you would like to see change by 2030? So we're going to give everyone about 15 minutes to share your expertise, and then we'll come back into the main room. If you'd like to nominate a rapporteur, that's absolutely fine. That would be wonderful. But if not, there's no pressure, and we will just be picking people at random. So everyone has been fairly warned. So I'm going to invite you all to select your room. We've got one on cancer medicines, one on cancer surgery, and one on kind of cancer within that broader health system. And we'd encourage you all to select your rooms and join your conversations. I'll also be dropping the conversations, the questions into the chat function, so everyone should be able to access them now. So we'd encourage you all to select your rooms and move ahead. Hi everyone, and welcome back to the main room. I very much hope you enjoyed your time in the breakout rooms. I managed to jump into one or two, and it was definitely a really rich discussion. I wanted to throw the floor open to anyone who wanted to sort of share their perspectives, or kind of if there are any key questions that you'd like to put to our speakers. Jane, I'm going to pick on you slightly because you had an excellent question at the last minute. But yes, so this is really the time that we want to kind of throw it open to you to pick the brains of our expert speakers if there's anything you'd like to ask them, and really kind of take that conversation to the next level. And
yeah,
Jane, over to you.
I'm happy to jump in and start with mine straight away. So the question that I had just asked, and then we had a few seconds to move into plenary, was about, we have, I'm really interested in access to cancer medicines, and particularly affordability of cancer medicines. And my question was, are there any good examples where we could point to and say, here's a good policy, a country with a good policy, a national policy, and that they're implementing and that they're doing well? And it doesn't have to be huge, but I don't know in your works whether you've found any good examples that we can then tag on to, and then see how well we can replicate that, so that we're not starting from afresh. If somebody's doing some good work somewhere else, maybe we can just replicate that instead of trying to reinvent the wheel. Yeah, thanks.
Would any of our speakers like to jump in on any particular examples that you think have been successful in scope or scale? Yehuda, I think you're on mute at the moment.
Yeah. You think I would have figured this out by now, but I think there are variable experiences within the sub-Saharan African continent in terms of access to medicines. I actually think about Kenya as one of those, like, on the better end of things. And I feel like there's a whole spectrum. There are like really great examples of the countries that aren't doing so well, and the people in the middle who are trying to figure it out. And I actually think about Kenya as sort of being in the middle. So like you mentioned, there's some medicines, but not all medicines ideally. And so I think there's the political will, there's some initiative to get started, but it's fallen short, in some areas. Regionally, and this is a conversation that I've had with Vivian as well, I think, countries that have been involved with food procurement seem to have really convincing data about being able to procure high quality medicines efficiently, but at cost effective levels, and maintain a sustainable supply of medicines. And so PAHO is an example. I think at the last World Cancer Congress, there was an example as well, actually, from the Caribbean region as well. So having, smaller islands pool their procurement together and procure cancer medicines for common cancers that are diagnosed within the country. And I think from a funding and expertise level, it just makes a lot of sense, and it seems to be a more sustainable approach. I think it also helps, in these climates where there's a lot of cancer drug stockouts and shortages, that when you have a bigger pool, you can sort of source from different countries when you need them, as opposed to doing solo procurement on a country basis. I mean, in Botswana, for instance, we see 100 breast cancer patients. Like, trying to procure ACT for 100 patients is going to be more expensive than the $30 per patient that Vivian mentioned. And so I think food procurement has worked well. There are clearly different challenges within the Africa region, and maybe Miriam can talk more about that from the AOTIC president perspectives, and how we leverage, the regional Africa, infrastructure to bring about food procurement. But I think really that is what I foresee as being like one main approach. And it doesn't have to be Africa, it can be regional, so Southern Africa or East Africa. But I think that might be the way to go, instead of every country procuring its own 100 vials of XYZ.
Thanks, Yehuda. And maybe I can just sort of speak to kind of what you're mentioning in terms of really the value of pooled procurement. And I'm seeing Vivian on the call, so she can perhaps talk to the Clinton Health Access Initiative that's trying to do excellent work in country in terms of trying to support the pooled procurement process. I think the challenge, at least in many African countries, has been a lack of willingness, perhaps to sort of share information and knowledge. And that's been one of the stumbling blocks. We shroud our procurement in, ceremony and pomp such that nobody quite knows what's going on behind the veil. And so it's really trying to think through, how do we normalize, these figures. We're like, again, because what we realize is people are initially hesitant about pool procurement. And then you realize, hang on, I'm paying 3-4 times the cost of the same drug and I'm just next door. It doesn't make sense. And so really, if we're able to streamline the process of not just procurement, but really the knowledge sharing and cost sharing as well, then that goes a long way towards, sort of, sorry, I'm just seeing Vivian's comments as well. Yeah, so that goes a long way towards at least ensuring better negotiation rates. And then maybe sort of a broader context, there has been a initiative, we haven't really, it's something on the landscape, Jane, but really around the AMA, which is the Association of, what is it? Medical, sorry, my brain has gone a little bit. The African Medical Association, I think, which is really trying to situation itself under the African Union, so that we can start to try and push from these from an AU perspective. Because if we're able to get clearance at that level where we accept the benefits of pooled procurement. I mean, the Clinton Health Access initiatives are phenomenal and great, but then how do we get the political buy-in of a broader set of players and make this a priority? So from an advocacy perspective, as Venus was saying, really about that sort of strategic advocacy, that's perhaps some of the things on the landscape that we should start help supporting from a local perspective. There's also an advocacy arm of that, I think the AMATA Association through the International Association for Patient Advocates. So it's really one of those things that we could also try and push forward in terms of actually seeing the actualization of the AMA objectives, which is really from a continental perspective, ensuring that access percolates down to every member country and every individual who needs it. Thanks.
Fantastic. Thank you so much for that, Miriam. And Vivian, for those of you who haven't seen, has dropped some really interesting comments in the chat, including how Nigeria is running a pool procurement across 21 public hospitals and seeing some success in 2022. And I wanted to sort of open up the floor to Vivian, if you would like to comment on that, or any of the CHAI work that Miriam referred to. I hate to put people on the spot, but I might also put you on the spot if that's okay.
Yeah, so I wouldn't. I think the biggest thing that we actually saw in both of these countries as examples was the buy-in at the highest level. In Nigeria, it was Professor Dewole, who's actually on this call, who really spearheaded getting all the chief medical directors from the hospitals together, getting them to buy into the vision of a pooled procurement, and then getting the regulatory body also in the process of thinking about availability as opposed to their paperwork that they have to work with. In Uganda, the parliament liberalized the procurement policy, enabling the Cancer Institute, which is the main public hospital, to manage cancer medicines as special medicines, and therefore procure them in a manner different to your typical paracetamol or cough medicine. So that helped the Uganda Cancer Institute to really source for high quality products, really negotiate better pricing. Of course, it also came with additional financing that they were able to advocate for. And that publication that I shared shows, improved availability, cost savings, increased patient visits, and of course, refills out of those visits. And so I think, you know, to Dr. Miriam's point, it's really, really important to have high buy-in, high-level buy-in. My only concern being that, you know, at what level should that buy-in be? Because at the AU level, like, how does it trickle down to the really operational issues that we face on a day-to-day basis between, for example, Nigeria and Ghana, or Uganda and Kenya? My experience is that there's a lot of, there's goodwill at the top, but there are also a lot of operational issues that tend to get the train stuck before it hits the tracks. And so, yeah, it would be interesting to see how the African Union can really get us going in terms of pooled procurement.
Fantastic.
Vivian, I mean, yeah, I was going to say, I mean, obviously you have a lot of experience here. And I think one of the points that I wanted to reiterate that you said is we really need to see the data. Like, I think a lot of the work that you guys have done is amazing. And it's great that you put in this publication. But I think if we can convince funders that they are paying more compared to, you know, if there's basically price transparency, there's also not a lot of price transparency. So like, you don't know what your neighbor is paying. You kind of know, but don't really know. And so I think if there's a lot of price transparency and we can see how much cost reductions have been attained, then I think that would be promising and hopefully convince funders. But I also think the AU might be a way to work through this, because I mean, if you think about power, it's essentially lifting the procurement. I mean, countries have to buy in, but then there are also opportunities to make this a mandate as setting cancer as a healthcare priority. And so, you know, I think that's the highest level. But I think if the mandates that come with it and the expertise is more at a AU level than like individual countries trying to figure it out, then that might be a mechanism that is sustainable. Because I think part of PAHO is that there's also an external funding, just like under PAHO, that provides funding for these medicines that countries then pay up for later. And so I think the AU idea is maybe lifting up the granularity and figuring it out from like individual ministries of health and focusing more, you know, beyond that. But I don't know, maybe Dr. Dewale and like other people can also comment on that.
Yeah, I was going to say, Prof. Adewale is on the call, so perhaps he can also give some perspectives.
Yeah, so much. Thank you so much, Miriam. I think the idea of pool procurement gained entry through South Africa, and we must commend South Africa, particularly when it came to buy in bulk anti-TB drugs as well as ARVs, and we learned a lot from them. And then we received encouragement from the Commonwealth. And that actually came into the Commonwealth agenda, pool procurement. There's a lot to gain when we practice pool procurement. Things are cheaper, bureaucracy is much reduced, and then there's the economy of scale, which one is not going to have if you start doing it independently. We're also sure of what we are buying, especially if you buy direct from manufacturers. So there's a lot to gain by pool procurement, and I think this should be recommended to quite a number of healthcare facilities, healthcare ministries across, not only in Africa, but globally. Thank you.
Wonderful. Thank you so much for that, Professor Adewale. That's excellent. And I think it's really nice to have those kind of such a concrete kind of next step, or you know, such a concrete opportunity that we can kind of engage with. Miriam, I wanted to come back to you if I may. I haven't seen any questions in the chat, so please raise your hands or drop the questions into the chat. Kind of picking up on your expertise within the kind of health systems perspective, but also specifically for cancer surgery, are there any good examples from the cancer surgery field that you've seen in terms of how we can kind of put this into practice, and what it is as countries look to implement UHC? Is there anything that we as advocates should be championing kind of along a similar lines to the medicines discussion we've just been having?
Thanks, Rosie. And I think one of the things to consider is really avoiding siloed approaches, and the challenges that we sometimes have I would say in Kenya, for instance, where we sort of have different counties. We have 47 counties, and every county wants to have a cancer center, a specialized center. So it's really about, similar to the approach to pooled procurement, is really looking at setting up centers of excellence to provide cancer surgeries. And so we've had excellent examples, for instance, within the NHS in the UK, where you actually have specialized centers managing cancers and similar things, similar centers in the US, but then sort of bringing it closer to the continent. We've seen excellent examples in terms of cancer surgery, where in West Africa, in Senegal, they've set up centers of excellence for providing urological surgeries, and so including prostate and any other sort of both benign and anything that's involving the urogenitary system. But that's really looking at, if we think about it, we do know that our broadest cancer burden, at least across most of sub-Saharan Africa, is breast and cervical cancer. So if we could extend the same sort of skill set and say we're going to set up centers of excellence that are addressing breast and cervical women's cancers in different regions, and acknowledgement that we can't build these systems across the board, and also trying to, it's that balance between having centers of excellence that are readily accessible, because the more you do, we always say, if you're going to have your cancer surgery, do you want to have a surgeon who's doing this every day, or do you want to have a surgeon who last did this procedure 2 years ago? So it's really about how do we develop those centers, and those centers it's a lot more, as I said, beyond the surgeon. It's the skills, it's the HR that's required, it's the equipment, it's the facilities, it's the data collection, and really looking at what are our outcomes, right? And auditing the entire process. So those go a long way. I would say some successes that have been done is through the aortic, actually, and the Pan-African Association, Pan-African Women's Association of Surgeons, where and the Surgical Society of Kenya, where we've tried to build, because by the time you're training a surgical oncologist, it's going to take you anywhere between 8 to 12 years, but then just along in terms of training. But then how do you empower the existing workforce such that you homogenize the training? And so there have been a couple of successful preceptorships that have been run around breast cancer surgery. We just recently did one last year around colorectal surgery and getting that multidisciplinary approach, because surgeons think that once they cut, that's it. So it's also really educating the entire team on the continuum to think about a multidisciplinary approach even before you have the surgery. It's getting the medical oncologist, the psychologist, and everybody else on board. So those are some of the successful examples that I would like to see at least amplified across the continent. Thanks.
Fantastic. Thank you so much for that, Miriam. That's really great. And Venus, I wanted to come to you as well. As are there any kind of, from your work that you've been doing, any kind of really successful examples that you think we can distill some of these lessons learned, so that actually once the UHC negotiations have wrapped up, and they're likely to do so shortly, and we're getting to the real meat of the process, which is actually seeing this being implemented from September and beyond, are there any kind of, have you seen any successes in your career, and what kind of factors help to kind of contribute to those successes? Again, I ask you really simple, really easy to answer questions.
Yes, thank you for that very easy one. Okay, yes, I think for Zimbabwe, from my experience, what I've seen is a successful cervical cancer screening program that is actually now in the community, where we've got HPV self-testing starting from the community level. And what has contributed to this is writing on existing programs, integrating, because cervical cancer was housed under the maternal and child health program. That's where it was housed, because of course it's for women. So we noted that it got a lot of attention, and they were able to leverage on the already existing MNHCH programs that were very strong, and actually be able to start implementation of some screening and other things using those funds that were already available, and also integrating it into the HIV program. So I think for me that's critical to not try and reinvent the wheel, not introduce cancer as a silo program, but to look at the existing programs, because it's the same patient we are taking care of. So looking at a patient-centered approach model to care, because it's this patient who's going to come to the facility for heart medicines, for hypertension, for cancer screening. So having that perspective actually helped to integrate, because we looked at the woman needing the service as opposed to the service being needed in the system. So yeah, I think that's an area I can share. Thank you.
Thank you so much. And I think, you know, we're drawing towards the half-hour mark, and I'm mindful of the fact that everyone has a lot of demands on their time. So I wanted to sort of pose one last question to each of our speakers and to any of the participants who'd like to respond, which is UHC, our current UHC commitments run through to 2030. So what is it that you want to see that is different by 2030? Venus, I'm going to pick on you again because you're really good at answering my difficult questions. So I'll come to you first.
Yeah, what I want to see being done differently, like I said, is looking at healthcare. It is looking at it from a patient perspective, having that patient-centered approach, because it then addresses a lot of issues, and having that lens, compassionate care lens to service delivery, how we program it. Because if you look at the concept of compassion healthcare, you actually realize it will address a lot of things, because you want to do the best you can for the patient you want them to access. So yes, I think that would be what I would want to see. Thank you.
Wonderful. Thank you for that, Venus. And then Yehuda, I think I'm going to come to you next, if that's okay.
Yeah, I think, you know, for me, primarily, I do think I want to see equal emphasis on treatment as we've had for screening. I think there's so many screening campaigns, 500,000 women march, 1 million women march. I think, you know, and the patient voices have driven this. And so I want to see the same emphasis that's been put on both of these screening programs for the cancers that we can screen. I want to see the same emphasis on treatment. I want us to talk about it in the same light and with the same seriousness, because the patients who are diagnosed now, you know, especially for things like cervical cancer, they cannot wait. And so I want to see the same emphasis as we put in on screening and tobacco risk reduction and all these risk preventive cancer approaches. I want to see that same focus and priority being given to cancer treatment and medicines access.
Fantastic. Thank you so much for that, Yehuda. I think patients cannot wait is a great kind of rallying call for it. And then Miriam, I'd like to come to you with the same question. What would you like to see change by 2030?
Thanks, Rosie. I think probably just to echo Venus and Yehuda's sentiments, it's really the recognition that the workforce is the bedrock of service provision. And without deliberate investments in the workforce, whether it's through screening or treatment, then we're not actually able to deliver the services. So I would really like to see the workforce come to the forefront, not just as an afterthought of the things we're doing, and really trying to develop a workforce across the entire continuum that's really trying to embrace, as Venus says, the ethos of patient-centered care, and really having the skill sets that are able to negotiate care that is respectful and, you know, appropriate and culturally acceptable in any setting. And so that's really what I hope that we will achieve by 2030.
Fantastic. Thank you so much for that, Miriam. And thank you to everyone who's joined us for the call and who's kind of shared your perspectives. I think I found this a very rich discussion purely because of your contribution. So thank you so much for that. And in trying to sum it up briefly, I think there are a couple of things that have really come out. And I think really looking at it from, as Venus said, from the patient perspective, and what are the touch points that patients already have with the health system, and how can we start to build those services in, moving, as Yehuda said, from primary and secondary prevention to kind of really responding to what patients need across that care journey. also working from a really strong data baseline, actually responding to what it is that we need, what it is that patients need, rather than our best guesses and our best estimates. And to Venus's point around that, data should also then include the experiences and the voices of the people who are providing the care, and putting that, recognizing the workforce is that kind of bedrock of our health system, but also the experiences of patients. And then the final thing that I'm going to be taking away, and I would encourage you all to do, is the importance of compassion, compassionate advocacy, and compassionate care. And so as we kind of look to September and beyond, I think on behalf of UICC, we're so excited to be able to work with our members and the broader cancer community to try and put some of this into practice. And really hope that this is the start of a much longer conversation that we can have at the World Cancer Congress and multiple points throughout the year. One thing to put in a very small plug is the UICC will be trying to draw together some of these successful examples, and so I'll be circulating the links and the comments that have been shared in the chat. But if you do have any further examples that you'd be happy to share with us, we'd love to be able to kind of curate these and compile these just so we can share that learning a little bit more broadly. So that I will now wrap up. I'm mindful of everyone's time, but it just leaves me say a heartfelt thanks to Yehuda, Venus, and Miriam for their excellent participation, and thank you all for joining us today, sharing your expertise and most valuably your time. I wish you a wonderful good morning, good afternoon, and good evening wherever you are, and we look forward to carrying on this conversation with you. So thank you very much, everyone, and take care.
Thank you.
Thank you.